Hello, everyone. Good evening. Hope everybody is doing well this evening. Welcoming everybody for our second last webinar arranged by SAJIDA Foundation by its mental health program under a almost 2 month long episodes of webinars. Today's topic is very interesting and obviously much needed discussion. Today's topic is residential mental health care. Let me just give you a bit of background so that we can continue with the discussion. In many countries, there are various forms of mental health services which are provided, a range of services, including crisis services, community outreach, peer support, hospital based services, supported living services, and community mental health centers. Unfortunately, mental health is still largely stigmatized across the world, and specifically in countries like Bangladesh, in this part of the world. In comparison to the most of the developed countries, Bangladesh is comparatively far behind in the development of mental health sector as a whole. The healthcare sector in Bangladesh had a twofold increase over the last 3 decades, whereas the institutional development of the mental health facilities had received very little attention. In the rush to progress our economy as a whole, along with priorities for the development of infrastructure, hospitals, and medical services, we ignored and failed to ensure mental health well being for every individual. As a nation, a country with a population in excess of almost 165 million, there are only 2 government-run mental hospitals. The dearth of mental health care facilities is obvious in Bangladesh. With 92% treatment gap, if you look at the numbers, there are 0.3 beds per 100,000 people, 56 general hospital psychiatric units, and 72 residential care facilities, according to WHO Statistics 2020. It has been observed that among the 8% of the people who are seeking treatment, mental health care, approximately 48% are getting treatment under unscientific methods. That's quite scary. The vicious cycle of incomplete treatment is causing a lot of damage to the population with mental health challenges in Bangladesh. As mentioned in the mental health strategy and policy, right-based issues are also a key concern in the available mental health facilities. A person who has the potential to recover from mental illness and contribute to the family's happiness gain self-sustainability, both financially and in the livelihood. It's but the fact is that they are rather stuck in the system with trauma, grief, and unspoken pain. Consequently, today's webinar is on the much needed topic of residential mental health care, focusing on the importance of functionality focused mental health facilities to bring about meaningful change in the mental health space. Let me introduce the speakers of today's webinar. Archana Padmakar, Deputy Director of Emergency Care and Recovery Center, the Banyan Academy of Leadership in Mental Health, and Mr. Zulkarnayan, Associate Professor, Bangladesh Health Professionals Institute, Consultant and Head of Occupational Therapy Department of Center for Rehabilitation of the Paralyzed in Bangladesh. And of course, our Dr. Ashik Salim, Head of SAJIDA Mental Health Program. Let me start with today with Dr. Salim. The first question to Dr. Salim is, in terms of residential care, currently what is the need and what are the options that we have for the people with severe mental illness who are in acute crisis in Bangladesh context? Please, Dr. Salim.
Thank you, Malkap, and welcome to all the other panelists. I'm looking forward to this session. very much. I'd like to start by saying that I have two hats. Well, one is I'm a consultant psychiatrist and the managing director of PHWC, which is um, a private facility for the outpatient care for people with mental health problems. And I am also the head of the SAJIDA mental health program. So I have two hats. So today I'm kind of going to talk a little bit from my clinical hat. I've been working in Bangladesh as a psychiatrist for the last 5 years, and 5.5 years. And before that, I was in medical school. So, as a clinician and as a psychiatrist, I see people at various stages of their mental illness. And today, I want to focus on the severe end of the spectrum. So, what happens when somebody is acutely psychotic, when they're violent, or they're suicidal? So, as far as services available in Bangladesh, our inpatient psychiatric care is kind of, or dedicated inpatient psychiatric care is limited to government facilities. So we have the National Institute of Mental Health, and we have the BSMMU, which is the postgraduate institution. Other than this, you have medical colleges, which will have a psychiatric unit and they'll have some beds. Now, having worked in various parts of the world, I have always seen that inpatient care is provided at different strata. So just one, so just government facilities or just private facilities or just NGOs running a facility is not sustainable because the the care is accessed by different people. In Bangladesh, what's happened is that our private sector inpatient psychiatric care tends to be limited to drug rehabilitation. So as a result, what happens is that we have facilities which are not dedicated to treating or are not specialized to treating people with mental health problems specifically. So this is kind of the kind of overview. Obviously, we have the National Institute of Mental Health. I'm not sure if I mentioned that. And we have the Pabna Hospital, which is a 500-bed hospital outside Dhaka. So we do have these facilities, and they are the government-run institution. I think today's discussion, I'd like to hear, obviously, about the different situations in Nepal and in India, and I'd like to hear uh, um, as well what's happening at CRP. Um, so I think that's just the overview of the current situation. Very often, we feel as clinicians, we feel that helpless because we can't offer the care to the people that we need. And I feel that there's a big gap where this needs to be filled. Those are my thoughts.
থ্যাংক ইউ সো মাচ ডক্টর সেলিম। আমি একটু যদি বলি যে আমাদের বাংলাদেশের সিনারিওটা ডক্টর সেলিম আমাদেরকে একটু জানালেন। সেখানে পাবলিক যে ফ্যাসিলিটিগুলো আছে পাবলিক সেক্টরে গভর্নমেন্টের আন্ডারে, এছাড়া প্রাইভেট সেক্টরে মোস্টলি ড্রাগ রিহ্যাবিলিটেশন আছে, মেন্টাল হেলথের উপরে কেয়ার বলতে গেলে অলমোস্ট নাই। আর যেগুলো গভর্নমেন্টের হসপিটালে কিছু সাইকিয়াট্রিক ইউনিট আছে অবশ্যই। এছাড়া আমরা প্রথমেই বলেছি যে এতই সার্ভিস কম মেন্টাল হেলথের, যাদের একিউট পেশেন্ট, ইন পেশেন্ট সার্ভিসটা এতই কম যে এটা নিয়ে আমাদের এখন অবশ্যই কথা বলা দরকার। আমি এরপরে যেতে চাই টু আওয়ার সেকেন্ড স্পিকার জুলকার নায়ান। We would like to hear from you about briefly, if you can tell us about the journey that CRP has taken for physical health, and how did CRP made this possible? Because it was, we all know that it's definitely an uphill battle that you have faced in establishing CRP in Bangladesh. And what can we learn, and how can we replicate in the mental health sector the journey that you have taken? And we also know that you have a unit for mental health as well. If you can give us a brief account of that as well.
Thank you, Malka Shamrojappa, and of course our honorable panelists from India as well as from Bangladesh. So it's great opportunity to sit with you and have a little bit talk about mental health and of course residential care. So as you mentioned that two different issues I need to cover in my speech. That is, one is how CRP is operating rehabilitation services in Bangladesh. And second part, I should cover that mental health service of CRP, that is residential care, how we are organizing those things in here. So first part, if I share with a little bit about CRP, that CRP, Center for the Rehabilitation of the Paralyzed, is established in 1989 with a great vision that to serve the people with disabilities in Bangladesh, and it is founded by Dr. Valerie Ann Taylor. You may have heard the name, and she is a British lady who came 50 years back, just before independence, that is 1969 in Bangladesh, and then later he during war she went back and come again and started her dream to do something for the persons with the disability in this state. And from then, CRP starts its journey with 4 patients. Now, in a year, CRP is providing around services for like 80,000 people are having services every year. And CRP is not only providing services in physical rehabilitation, at the same time, CRP is trying to generate human resources. As you mentioned, a lot of gaps regarding the health and mental health. So she thought in such a way that it's not only that to provide services for the persons with disability, but also to create skilled manpower, those who can provide services for the people with disabilities, including mental health. And accordingly, she established Bangladesh Health Profession Institute and started different training programs, including occupational therapy. And just I can mention myself that when I come as a student in 1999, then as part of our program, we started mental health care. Like when I was a student, I have been in Pabna Mental Health Hospital, so I got the opportunity to see how they are operating services, especially the rehabilitation care in Pabna Mental Health Hospital. And from then 2000, we started our little bit services with National Institute of Mental Health in Dhaka, and then we continued their services. And how CRP operated services in CRP, especially the rehabilitation, if I tell a little bit on that, that CRP, as you know, that it's a charitable organization, so it's not for the making money, it's just a surviving hand to mouth, and providing this huge number of people every year, as I mentioned earlier, around 80,000. And we are providing like the subsidized costs, but the question is that how CRP sustained the last 40 years with a subsidized service. That is the huge questions asked by so many people, that how CRP doing these jobs. And in this regard, how CRP is trying, yes, at the beginning it was really very much depend on the foreign donations, and different organizations from different part of the world, they are contributed to sustain. And gradually CRP started that yes, we need to be sustainable, and CRP tried to generate some sorts of funds, like the like adding some values of the services, like the how the people are getting services. Though then we started that we encourage people to contribute, and we started like such a way that those who have financial capability, they will pay, but those do not have financial capacity, they no need to pay. CRP will generate funds for them and continue services. But our motto is nobody will left from CRP without rehabilitation, without treatment. And CRP is providing services like the acute care, as well as the intermediate care, and also the community reintegration, rehabilitation and community reintegration, all those stages. Like for example, I can say that somebody having injury, like a spinal cord injury, when they're coming, it's like the very early stage. So we started from the very first stage, then we go through like the acute, active, then rehabilitation, then we gone through the like the community reintegration. We in the middle we have like the halfway hostel. It's like a what is a different word, maybe like what it means, the halfway hostel. We love to say it's like transition period. So somebody come from the rural community and having treatment in the tertiary level hospitals or rehabilitation centers, so need a transition period. So CRP established from the very beginning like a transition house, which we call the halfway hostel. So after completing the hospital or rehab center or institutional based rehabilitation, so we kept them in a like couple of weeks to keep them, make them independent, that they prove themselves they are fit for return to their own community. So they stay there a couple of weeks, show their skills and performances, and at the same time we visited the community and check with their family members, community people, talk with them, and then reintegrate those patients within that community so they can play their role in their community. Even if we need to advocacy on that issue, even CRPS is doing that. So like for our physical disability, so it's like CRPS, we love to say it's like a lifetime member with CRP. So CRP is continuing those follow-ups throughout year, like the certain interval. So how they are doing their lives over there. So this is how CRP operating our physical disability and challenges. And the same issues, actually, same things we actually try to replicate our mental health services also. As I mentioned earlier, that from the very early stage of our education system, we introduced with the mental health. As you all know, that OTs are playing a very great role in mental health rehabilitation, along with the psychiatrists, psychologists, clinical sociologists, workers, and others. So they are starting that job very early stage. So we involve National Institute of Mental Health very closely, and CRP continued support to National Institute of Mental Health to survive the rehabilitation over there. And last couple of years, I think I can remember that like 2014, we thought that like, we need some new initiatives, that is come the concept that mental health residential care services, and how the concepts come from you know, they say the Western concept, but we try to adopt those in our context. And we started a new project with the residential care, that the day center for the mental health needs, with our support from different level people, and especially support from the Kaduri Charitable Foundation Hong Kong. They are supporting a lot us regarding these issues. So if I tell you little bit about the this residential care, how CRP is, what CRP did with this, like the last 3 years, we did around 500 patients with mental health needs. They got support from those this project, and we around 10% of those patients we did complete rehabilitation in their community level, including their treatment in government tertiary hospital or private clinic, then come for the rehabilitation, stay in our residential care for like 2 weeks to 8 weeks. Usually we depend on the patient condition and their other issues. So they stay here, learn different skills, involved in the vocational training. According to the training and interest, we find out the suitable rehabilitation process in the community level. Then they return back in their community. So around 10% of this group completely independently rehabilitated in the rural community. So CRP is trying to set an example that yes, it's possible with this trip. If I just tell you a little bit about what major activities we did in our mental health, this day center activities, like we had like comprehensive rehabilitation services over there, that we had psychiatric consultations, psychosocial counseling, occupational therapy services, social work, CBR work, that is how we visited community regular intervals. Then we provide medication supports. We provided transportation supports to them to bring them in the day centers and return them their own home. So the early morning they can come, and end of the day, evening, they can return to their home. So they can be like a what is it? We don't. We always try to involve the family members in this process, that they are the part of our rehabilitation process also. And we provide food facilities, how long they stay in our day center. So like the breakfast, lunch, and those who had stay our residential facilities overnight. So we provided evening food also. And also like the vocational training facilities, as I mentioned earlier, the CRP is, the huge organizations have different sorts of rehabilitation facilities, like vocational training, like tailoring, like sewing, like garments work, like the garment machines operation, those operators, those type of trainings we have. Even we have like the beekeeping, we have like mushroom cultivation. we have like crafts work. So we try to in like metal work, wood work. So different type of activities we have in our setting. So we try to include them in their facilities, so they learn life skills, those they can use in their further life. As well as our team made regular interval home visits to make them like the family members and relatives to bring in the rehabilitation process, and also have like a phone follow-up systems, outing programs, like a team with mental health clients go for the outing, like the sharing, entertaining, and a lot of the I think you all understand that this is the way how CRP is trying to reintegrate the patients in the rural communities. So
Thank you so much. It's definitely very encouraging for all of us. We are very proud of the success story of CRP. There's so much interesting points were made here. যেটা সবচেয়ে ইন্টারেস্টিং হলো যে কিভাবে সাস্টেইনেবিলিটি এবং ফিনান্সিয়াল মডেল, একটা তো সার্ভিস মডেল এবং এটা কমপ্লিটলি রিহ্যাবিলিটেশনের উপরে ফোকাস করা, কমিউনিটিকে ইনভলভ করা, তাদেরকে আবার কিভাবে ফেরত যাবে তার নিজের কমিউনিটিতে, সে রুরালি হোক আর আরবানই হোক, তার যে ট্রানজিশনটা কিভাবে হবে এগুলোতে উপর ফোকাস করা। বা তার থেকেও বড় হলো যে সাস্টেনেবিলিটিটাতে যদি আমরা ফোকাস না করি যে কোনো মডেলে, that is one of actually deciding factor that if we can't attain sustainability, তাহলে otherwise it will be very difficult for any project or any initiative to bring about the
just one tiny
desired
point
success.
I can add, that is the question of sustainability. That is, CRP is now almost 75% generates from our own services, that is local activities. So that is how CRP is trying for the sustainabilities.
That's very very encouraging. 4 জন পেশেন্ট থেকে এখন 80,000 পেশেন্ট per year. It's very encouraging for all of us. Coming to Archana, we would like to know from you, in terms of residential care, what are the options for people with severe mental illness and who are in acute crisis in India, in Indian context. We would like to hear from you on that.
Yes. So within the Indian context, as you know, it is not too different from how it is in Bangladesh. So here again, a common man who's struggling for less than $2 per day is probably a person also who needs to access mental health services. So within that perspective, it is difficult for a common man in India to access mental health services, which is completely free, because that is what he needs. So in addition to the added distress with regard to poverty and stigma and all the environmental determinants or the social determinants which is probably precipitating a mental illness, because mental illness does not come from nowhere, isn't it? So it's a combination of your environmental factors, your social factors, your psychological factors, and your individual factors in an individual. So when that so happens, we do not have a lot of facilities who can offer these sort of comprehensive mental health services for a common man who's going through a lot of distress. So in that way, if you see, the Banyan since 1993 has brought in free mental health services for people who live below the poverty line and who belong to ultra vulnerable population and marginalized communities, who also belong to different castes, irrespective of whether they're able to afford or not. So that sort of vulnerable communities are the population who are accessing our services. So if you see, one is about the service factor, as Dr. Julkar also had put it in a very right way. One is about sustainability, one is about the service factor. But what's more important is how are we packaging these mental health services for somebody who cannot afford? Are we doing it as a charity, or are we doing it as an integral part of the health system itself? So that's very important. So we don't do it because somebody is poor, we don't do it because it's needed, or we don't do it because we want to be unique among in the market space. Why we want to do it is because 70% of our Indian population are also going through a lot of distress in terms of economy, in terms of financial crisis, in terms of so many other factors, considering the fact that during the pandemic situation, or even before that. There's been a lot that people have been through, right? So from that perspective, it is very important that do we have a place where a person can access acute care services in a very comprehensive way. At the same time, is it very user centric? So that sort of a mental health care system is what is important. So how we are able to integrate health where it has both components, that is general health and mental health, is very, very important. So we are not stigmatizing that mental health is specialized care. It doesn't have to be that way. So health has both components which need to be equally counted in, which is why the Banyan has integrated both health and mental health as part of acute crisis management, which is why we have the emergency care and the recovery model. And the emergency care recovery model brings in homeless people with severe mental health issues. So when they have acute symptoms, or people from the ultra vulnerable community are brought into our system, and they stay over a period of maximum at 6 to 8 months. And after a period of recovery, because we have a multidisciplinary team in place comprising of psychiatrists and psychologists and social workers and peer advocates. So in combination of this, when they recover, we identify their families and they go back to their families. Now this is also a very special and very vulnerable population, because all those who have mental illness don't become homeless, right? At the same time, all those who are homeless do not have mental health issues. So which means there is a clear correlation over the fact that whether you're educated, whether you come from an affluent family, it really doesn't matter. But there's a downward spiral if you have a mental health issue. In addition to that, you have several other factors in terms of social factors, in terms of psychological factors, which is probably putting people at stake, where you're not able to access even the simplest of the services that is probably need to be there for a common person. In addition to the emergency care and recovery center, what we have done, like working towards sustainability, we felt that it's not the CSO's primary responsibility to cater these services to a larger population, which is why we've tied up with the National Health Mission. So the National Health Mission is where we are looking at, we have collaborated with the government of Tamil Nadu. Tamil Nadu is also a state in India, in southern part of India. So here what is happening is we have replicated this model across 10 districts in the state. So this model is placed within the government hospital itself. So instead of us expanding in those districts, what we have done is we've identified local CSOs, local NGOs, but the whole program is run by the government staff as well. And we do the capacity building. So we bring in the technical aspects in terms of how to go about initiating an ECRC, how to develop the quality of the program, how to develop a comprehensive mental health care package for people who come from rural backgrounds. So now what we've done is, since the Banyan is also situated in one of the urban regions of the state, which is Chennai, we wanted to spread across the rural districts in Tamil Nadu. So the Banyan runs about a 200 bedded IP facility in Chennai. In addition to that, we have 250 bedded facility only in the government hospitals. So now people have stopped coming by mortgaging their only house, mortgaging their only land, mortgaging the jewels, and coming all the way to Chennai or to any sort of institute of mental health. But what people can do today is they can access those services in their own rural regions. So now in the 10 districts that we have, in the next 1 year, we are going across all the districts in Tamil Nadu, which means the state of Tamil Nadu has about 32 districts, and all the 32 districts will have the Banyan's model, which is the ECRC model, which will be situated inside the government headquarters hospital itself. So in addition to this, what is also important is having an outpatient services which is also looping into the inpatient facility is very, very important. So in addition to the residential care program, however important is to bring in somebody from the community into our system, what is also important is what happens to that person who goes out of the system. How is that person doing? Is that person doing fine, or are we discharging? So every exit pathway, every discharge does not mean it's a success story. He has obviously exited the hospital system for sure, which is a good thing. But how is the person doing now? Because Nothing of his scenario changes once he gets back home, isn't it? It's the same alcoholic husband, or it is the same spouse who has a mental health issue, or it is the same child who has a developmental disability, or it's the same unemployment, or it's the same scenario where I'm not in a position to gear up myself and get out of my bed. If that is the situation, are we still in touch with that person who's going through distress and going back to the same environment? So we are doing our best to change the person, to change, to bring in a lot of innovative care packages to make the person feel better. But what once he goes back into the family, because the family doesn't come into the admission part of it. We work with families as the residential program continues with a particular individual. But what happens to the person after they go back? So continuity of care, and this is what the World Health Organization also endorses. So the WHO also tries to endorse the fact that continuity of care is very important. So the Banyan very much endorses acute care services for people who are homeless, people who are living in marginalized communities. In addition to residential program, what is also important is the important component of a residential program is continuity of care.
Thank you, Archana. Very, very rightly put, very aptly said. As WHO says, the state of complete physical and mental and social well-being, and not merely absence of disease or infirmity. That is what a definition of health. So interestingly, this ensuring the accessibility of mental health services at the rural level, or at the not focusing on the urban areas, and making it available for everybody, and the collaboration between government health system, NGOs, and other organizations who would be able to provide this, will make this journey easy for everybody. Another important aspect that Zulkarnain and Archana, both of them made, is the capacity building. Making a mental health service available and making it accessible definitely is dependent on building the capacity of the people, making community level workers aware of the mental health services and making them part of the system. Let's go back to again to Dr. Salim, and coming back to the question about what actions can we take now, and what could be the way forward to develop affordable and residential mental health care for people with mental illness. Let us focus on Bangladesh first, and let's start with Dr. Salim.
Thank you. It was so interesting listening to our two speakers, one from the context in Chennai and also from CRP. So um, I think if we look at the way forward, essentially what Archana said is really important, that they set up a service, and then they saw how that they could integrate that into the government services, and how you can actually work alongside the government. Because I think unless we do that, then there's uh, we won't be able to go national with a project. I think in Dhaka, one of the things is that we don't have that many NGOs or non-governmental organizations providing clinical care. And I think CRP is quite a unique example there, that they're actually providing intervention. So while we have a number of NGOs which may be working with mental health, we don't have NGOs that are actually providing a clinical intervention. Um, as a result, what we have is we have the government service and we have private services. So I think Sajida Foundation over here, I feel that we are in a unique position to be able to provide some high quality clinical services, including residential facility. Now, we feel that there's a little bit of a gap here, in the sense that we have inpatient beds in the medical colleges and in the in the big mental health hospitals. But as far as like Dr. Archana mentioned, a patient will come and spend 6 to 8 months and receive full-time treatment, therapy, intervention, rehabilitation. It's a complete gap that we have in our system. And I've visited the CRP program, and it's wonderful. People come, and it encourages that day activity, but I think it's for some people, for example, the homeless people who do have some kind of a chronic mental health problem. So probably most commonly it's schizophrenia. So people who have a schizophrenia, they're on the street, they're estranged from their family, and essentially they live off the charity of people, and then eventually they'll come to some kind of untimely demise. And there's they completely skip through the nets in Bangladesh, and they don't have. So we feel that we're in a unique position, and it's so interesting talking to the Banyan, because we find that our intentions are now where Banyan started about 20 years ago, with that kind of intention, and that's why we're so keen to be able to work together so that we can accelerate our process by starting where they started, learning from them, and then obviously adapting it into the local context, and being able to provide a more holistic service. So I think with regards to the way forward, the first thing we need to think of, and what we're trying to do, is we're trying to set up a place where people can come and stay, 3 to 4 months, where they can receive rehabilitation, occupational therapy. Hopefully, we can do it in collaboration with the CRP, because they are the trainers of the best OTs in Bangladesh. So, we have an OT-run center where people come. Obviously, the clinical services, the counseling and psychiatric care. We have PHWC and the SAJIDA other services, for example, Shajon. We had a webinar about before. And we can provide the clinical interventions. People can stay. SAJIDA Foundation as an organization provides microfinance as one of its core functions, and medical services, general medical services, both general and especially in COVID, they've provided specialized COVID services across the country. So I think this unique collaboration between all these different organizations will be able to allow us to provide or develop this model where we can provide this inpatient care for people with severe mental illness, following so when not necessarily using the acute model, because we'll have to work in collaboration with the government to do that, and we hope that's the way forward. I guess the final thing I'd like to say in this matter is that, and then again, the issue of capacity, the issue of human resources, because we can't produce mental health OTs fast enough. We can't produce doctors fast enough. We can't produce psychologists fast enough. But we can produce paraprofessionals. We can produce, lay counselors. We can produce support workers or care workers. So again, we're working in collaboration with the Banyan to help start this training, and the TOT is going on right now. So very soon we will be able to start training a different strata of professionals, because we're moving away from the voluntary model and have professionals, but people whose training and education level is maybe not that high, of having to produce people with masters, and getting them to provide the hands-on care while we provide the supervision. And that way, hopefully, we have a model which is more diverse and obviously cost effective. So thank you.
Thank you, Dr. Salim. That's very interesting, because I think that is how CRP and Banyan is making a headway by providing building capacity at the paraprofessional level, and which will be also kind of a deciding factor for us as well. আমাদের প্যারাপ্রফেশনাল তৈরি করার এই জার্নিটা ডেফিনেটলি আমাদের সবারই হেল্প লাগবে এখানে, এবং কোলাবোরেশন সরকারের সাথে, institution like CRP, institution like Banyan. We would be seeking support from you and collaboration from you to take it forward. ইন্টারেস্টিংলি আমরা বারবারই দেখছি এই কোলাবোরেশনের কথা এবং ক্যাপাসিটি বিল্ডিং এর ব্যাপারটা, এগুলো যে কত ইম্পর্টেন্ট এই পর্যায়ে, এগুলোকে যদি আমরা অ্যাটেনশন না দিই তাহলে আমাদের সাজেদার ইন্টেনশন, সাজেদা being an advocate for health, happiness and dignity for all, where focusing on mental health resonates very well, because কোনোভাবেই স্বাস্থ্য এনশোর করা যাবে না আনলেস, যেটা ইভেন অর্চনা বলেছে যে মেন্টাল হেলথকে আলাদা করে দেখার স্কোপ আমাদের নাই, আমাদেরকে হেলথের একটা অংশ হিসাবেই দেখতে হবে। এবং এই ডিসকাশনে এগেন আমি আবার কামিং ব্যাক টু Zulkarnain, posing the same question, what actions can we take now, and what could be the way forward to develop affordable residential mental health? আপনি যদিও এটাকে অ্যাড্রেস করেছেন কিছুটা আপনারা মেন্টাল হেলথ প্রোগ্রাম দিয়ে, তারপরেও যদি আরেকটু এলাবোরেট করেন, it will be also we'll be able to learn a bit more from you.
Well, thank you again. And yes, what CRP is trying, as I am occupational therapist, as I also am leading my organization, Bangladesh Occupational Therapy Association, and 27th is October is the World Occupational Therapy Day, Mental Health Day, World OT Day. We are celebrating together, you can say. And within this drive, just 20th of this month, we had a roundtable discussions in Dhaka. We got some distinguished people to talk about, like Minister of Social Welfare, Minister from Disaster Management, BCs and Pro-BCs from Joshua University, from Chittagong Medical College University, one professor from Dhaka University who are involved with the rehabilitation, and journalists. So it's a huge discussions. Why I bring these issues, that it was a great discussions regarding rehabilitation. And of course, we are talking about the mental health, and if we want to do this drive and want to get the success, we need PPP. That is what Dr. Selim and Archana, and you also mentioned that partnerships between government, private organizations, entrepreneurs. So only this collaboration can help or can sustain these issues. And we got very good commitment from Dr. Pran Gopal, though he is a specialist on ENT, but he rightly mentioned that the need of rehabilitation, that is, he very strongly pointed that the comprehensive rehabilitation, because if we want to achieve SDG without comprehensive rehabilitation, it will not be possible. So government also giving a special attention on that we need to take a special attention on that issue. So it's a good time to initiate partnership with the government, private organizations and entrepreneurs, that how we can set a program or projects to do this, take this challenge in future. As a lot of surveys in the national level, we found that the mental health challenges is nowadays is becoming very higher in comparing with other countries, especially in Bangladesh. So government also aware on these issues. So now it's, I think, great time what SAJIDA taken the initiatives, that is the collaboration as well as initiatives for the residential care. As you rightly mentioned, that whatever the services have throughout the country, it's not the complete rehabilitation. It's like the part of the rehabilitation, a part of the medical care, part of the services. So now we need a comprehensive program from the beginning of the the disease process. We need to work throughout the process, even need to continue the follow-up. So this is, I think, the right time what SAJIDA initiated. So far I got the opportunity to talk with you people and some other colleagues with SAJIDA, that it's the right time that we can do some collaborative efforts. And also from the roundtable we got recommendations from that to take initiatives to generate manpowers in short term as well as long term, like what Dr. Selim rightly mentioned, that we need some short term programs that we can generate some short course to immediately create some manpowers that can provide service. At the same time, we are trying to collaborate with universities trying to convince them to open different educational programs that can create right manpower for the right person, right rehabilitation. Because without government involvement, without public involvement, it's not possible actually. So we are working the same drive with you to generate skilled manpower. At the same time, we are working advocating with that, not only creating the manpower, also to put those manpower in the government systems also, not only in the private sectors, because it's not possible to serve the whole nation within the private sectors or NGO sectors. So we need a collaboration in these parties. So thank you again.
Rightly said, Mr. Zulkarnair. Again, we are coming back to this again and again about capacity building, and the dearth of human resource is very obvious. And we know developing a doctor, developing a psychiatrist, developing a counselor, what do you call it, counselors and psychologists would be very difficult, and we can't do it overnight. So in the meantime, we have to have this trainings for paraprofessionals, and we are not saying that we will be compromising on quality. We will be providing a quality service with quality level of training, so that we develop a cadre of paraprofessionals who would be able to fill the gaps, because we live in the part of the world where we know that there is a lot of gaps in the capacity development, and we need to work, all of us together. Here also we need a lot of collaboration, as we are again and again coming back to the same point. Archana, coming to you with the same question. How do you see what's the way forward in developing affordable mental health, residential mental health care for people with mental health illness? It can be India, it can be Bangladesh, it can be anywhere, but we need, because from your experience, you've been doing it for a long time, we can all learn from you. Archana,
Yes.
please.
Malka, is it possible to add my co-facilitator?
Of course. Please introduce her, and then definitely please add her.
No, she's already there. I think she has been in the backstage. She's not visible. She's logged in.
Yes, we're seeking. There was another participant at the backstage. ওনাকে আবার add করে দেওয়া যায়? Archana, you start, and I'll ask them to add her back.
Okay, sure. With regard to affordable mental health programs, I think I did propose the model of having a public-private partnership with the government. I think it makes a lot of sense to do that. But there's another thing that we've also done at the Banyan as well, where I would really like to highlight the fact that unless we experience certain experiences, it's difficult for us to put forth a paradigm of care. It's very difficult. Okay, now that is why at least 30 to 40% of the Banyan human resources comprises of people who are user survivors, or who've been through homelessness, or who've been through severe mental health issues. And that's what we believe, because I have read a lot of textbooks, and so I think most of you have come from very esteemed institutes where people teach us very prescribed models based on what the Western world is teaching us. But what we would want to go by the experiences of individuals, learn what user survivors want from us, and then accordingly make changes in our system so that we are able to bridge that gap, not only in terms of number of human resources, but also in terms of what sort of resources are we trying to bring in, so that the user survivor feels that yes, my needs are being met. Unless we hear from a user survivor, it's very difficult for us to bring up a framework and say this one size fits all. Okay, so I would like to introduce my co-facilitator, Miss Porcelvi, and she works as my colleague at the ECRC and at the headquarters hospital at the Banyan. And so I would like her to express her perspective, so that we also get to know how else we can resolve this issue. She will speak in Tamil, which is also the local language of Chennai, but I'm very happy to translate. ஸோ பொற்செல்வி, ஸோ அவங்க
சொல்லுங்க.
என்ன கேள்வி கேட்குறாங்க அப்படின்னா, இப்போ நம்மளோட மென்டல் ஹெல்த்ல பாத்தீங்கன்னா நிறைய பேர் வந்துட்டு வேலை செஞ்சு அதுல வந்துட்டு நிறைய குறைகளும் இருக்கிறது இல்லையா? அப்படி இருக்கும் போது உங்களை மாதிரி குணமாகி அங்க வேலை பண்றதுனால இன்னும் உபயோகம் இருக்கு இசிஆர்சிக்கு?
அதாவது மனநல பாதிக்கப்பட்டவங்களுக்கு நாங்களும் ஹெல்ப் பண்றோம். சமுதாயத்துல ஒரு நல்ல எண்ணம் மனநல பாதிக்கப்பட்டவங்களுக்கு வரணும். அந்த மாதிரி இருந்தா நல்லதுன்னு பப்ளிக்ல புரிஞ்சுக்கிறணும். அதே போல கவர்மெண்ட்ல இருந்து கிடைக்கணும், டிசபிலிட்டி கார்டு கிடைக்கணும். அதெல்லாம் எங்களுக்கு பேனின்ல வாங்கி கொடுத்துருக்காங்க. பேன் கார்டுக்கு நானே முயற்சி பண்ணி நானே வாங்கிக்கிட்டேன். அப்புறம் வந்து எங்களுக்கு நல்லா பேனின்ல பாதுகாப்பா இருக்கும். பெண்களுக்கு முதல்ல முக்கியம் பாதுகாப்பு, அது பேனின்ல கிடைக்குது. நாங்க ஒரு நல்ல வேலையில இருக்கோம் பேனின்ல. அவங்க வந்து சேலரி கொடுத்து எங்களை ஊக்குவிச்சு சமுதாயத்துல ஒரு நம்பரா நாங்களும் பேனின்ல இருந்து டிஸ்சார்ஜ் ஆகி வீடு எடுத்து கொடுத்து எல்லாம் பாக்குறாங்க, மாத்திரை மருந்து கொடுக்குறாங்க. ஆனா கவர்மெண்ட்ல டேப்லெட் அந்த மாதிரிலாம் கிடைச்சா நல்லா இருக்கும். உங்களுக்கும் கவர்மெண்ட்ல கொடுத்தாங்கன்னா அந்த மாதிரி உங்க பங்களாதேஷ்ல இது பண்ணாங்கன்னா நல்லா இருக்கும். எங்களுக்கு ரொம்ப ஹெல்ப் பண்றாங்க பேனின்ல. நாங்களும் எங்க பேஷண்ட்கள் நல்லா பாத்துக்கணும் அப்படின்னு நினைக்கிறோம்.
தேங்க்யூ பச்செல்வி. சோ நீங்க மியூட் பண்ணிக்கலாம். நீங்க ஒரு நிமிஷம் மியூட் பண்ணிக்கோங்க. So what she was trying to say is she also spoke briefly about her journey, that she was homeless and then she also had a severe mental health issue, and she accessed the Banyan services, and now she is part of our care program. And in addition to that, what she said was the advantages of having peer advocates, the advantages of having user survivors as part of the care program is where they can bring in the nuances which probably the care system is not in a position to understand. Second, she said that it brings a different level of confidence to people because they are in a position to suggest what works and what doesn't work in a care system. Third, what she said was there is availance of several other benefits only because we are normalizing the individual by absorbing the individual into the care system. So she says that yes, there is a dearth of human resources, but if you normalize it by engaging the person as part of the care system, it normalizes our lives a lot more better, rather than me only taking medications from the Banyan, rather than me taking only disability allowance, rather than me only being supported to get a PAN card. If I'm part of the system, then my life is far more normalized and I feel so much part of the system, and also I'm able to bring in those nuances along with everybody in the team, in the clinical care team. And the fourth point that she said was it's a game changer for us. For people like us, it is a game changer when not only qualified people have a significant role in bringing about the change, but even people like us are in a position to bring about this sort of fixing the gap and dearth in human resources, and especially in understanding the care paradigms. So for example, there's also a huge friendship between our family and Porchelvi. She also has her family has denied to take her back, but then there's a lot of foster friendships that has formed over the years, if you see. So though she came into our ECRC facility, she also accesses the continuity of care through our aftercare program. In addition to that, as you all know, the Banyan's home again model, which was recognized by the World Health Organization as one of the best practices model in mental health. So she also accesses our home again model. So she shares a house in the community with 5 other women who are also user survivors, and they are completely normalizing their lives by having their own jobs. So another person is a beautician, another person is a nurse, another person is a cook, she is a peer advocate and my colleague, another person is at home, she doesn't like working, so she's at home. So each of them have their own experiences and they feel so much uh, there's this deep sense of belongingness, which also is very important as part of a care system. So despite the dearth, despite, so I think this dearth will never end. It's like the Alice in Wonderland, the wishing well. I think it'll keep going on, it'll keep going on, because as you know, the number of people who probably require mental health services is drastically going up. So where are we going to find those people who can probably cater services to this sort of a population who's on the rise, right? So, and the onset of alcoholism is not anymore 14 or 13, it's at 4, it's at 6 years in Chennai. So a 4-year-old boy or a 6-year-old girl is at the verge of getting hooked on to a substance use. Now that has been drastically coming down. So if that is so, then we need more and more people who've been through this experience, who've been stigmatized, who've been ostracized, who have been through so much trauma, telling us what we need to do. I think that's the way to go about it. It needs to be a good balance of people who are qualified, who are technical, who are clinical. At the same time, also have people who've been through this sort of a trauma.
Thank you from bottom of my heart for bringing Porcelli into the conversation. That brings us, gives us the perspective that we need. We understand how deep the issue is, and as you're saying, we know we are in a. It's definitely an uphill battle for all of us, for a country like Bangladesh, for a country like India. But seeing somebody like Porcelli gives us hope. Thank you again. For sharing this with us. Please do thank her from us. And this, as I said, that this gives us a kind of an understanding that is needed for all of us. I would like to go around one more time. If you have any now concluding remarks, Dr. Salim, do you have anything to add to the discussion?
I'd just like to thank everybody for giving their time on a Sunday night to help this conversation goes on. You know, we have some very good well-wishers, supporting us in the work we do, and we feel very blessed today. Being introduced to Ms. Porcelli was a pleasure. So I hope I can come over to Chennai soon and meet you, which will be wonderful. And I think that's all I have to say for today. Thank you for your time and hope to see you soon.
Zulkar Bhai, do you have anything else to add here?
Thank you so much. I am fully agree with Dr. Archana, what she mentioned regarding the peer support, what CRP is trying to create peer support, and of course, like the befrienders group. So we are working on the same board. So I think it's a great things to learn and doing with this. And of course, special thanks to SAJIDA Foundation to take such a wonderful opportunity, initiatives to take the mental health a step ahead. So, and of course, we are lucky that we are in this. We are able to get the opportunity to be part of this initiative. So, thanks again on behalf of CRP.
We will take the journey together. Archana, anything to add?
Yes. So I would like to thank the other esteemed panelists here, Dr. Ashik and Dr. Julka and Malka. Thank you for putting things together so beautifully. And I think it's a wonderful collaboration, bringing in the context of within Bangladesh and in India. And I think it's very important because there are similarities, yet there are differences. So I think it's good for us to work together in partnership, I think. And all of us are on the same page and in the same boat. So that's something that I completely in agreement with. And that's very much required for us to bring about a specialized care services for people who are in great distress, especially for those who come from marginalized communities. So thank you for this opportunity, and I would like to thank on behalf of the Banyan and BAM as well. And Porcelli would like to add something. She just messaged me. Is it okay if she also adds something? Porcelli, நீங்க எது சொல்லணும்னு சொன்னீங்களாமே, கொஞ்சம் சொல்ல முடியுமா? சொல்லுங்க.
மேடம் நாங்க வந்து வேலை பார்க்கறதுனால எங்களுக்கு எல்லாமே நாங்களே சமுதாயத்துல இருக்கிறதுனால எங்களுக்கு விரும்பினதை நாங்க வாங்கிக்கிறோம். அது எங்களுக்கு ரொம்ப சந்தோஷமா இருக்கு. எங்க ஃப்ரெண்ட்ஸுங்க கூட நாங்க நல்லா என்ன இன்னைக்கு சாப்பாடு செய்யலாம் அதெல்லாம் யோசிச்சு டிசைட் பண்ணி சாப்பிடுறது கன்சல்ட் பண்ணி பேசுறது ரொம்ப நல்லா இருக்கு. இந்த மாதிரி எல்லா இடத்துலயும் ஆரம்பிச்சா இன்னும் நல்லா இருக்கும். அதே போல கவர்மெண்ட்ல இன்னும் அதாவது கொஞ்சம் உதவி செஞ்சா நல்லா இருக்கும். வீடு கிடைக்கிறாப்ல அது நம்ம முயற்சி பண்ணி கவர்மெண்ட்ல கேட்கணும். அது கொஞ்சம் பண்ணணும்னு தோணுது.
சரி. So Patini said that நீங்க mute பண்ணிக்கோங்க. Thank you. So what she said was there are three things that she emphasized on. One was she said that in addition to the friendships and all of that, there's a sense of choice. So in terms of the care service that I want, and in terms of what I want to do in my life, there's a principle of choice based on which the care program is designed. So that is what I think people like us require, is what she said. Second, she said that I have the choice of looking at what sort of employment I want and in what sort of family that I want to live. There are multiple choices in terms of what sort of friendships you want to have, what sort of people you want to live with. So that sort of diversity brings also us together, is something that she said. Third is, for people like us, when though we have families and families are not in a position to accept us post a mental health issue or post several other factors or traumatic events in their lives, she's saying if the government can facilitate a housing program for them, because instead of the CSO not bearing the brunt of a financial liability in the long run, but if the government can raise that sort of funds to sustain by bringing up a housing program for those individual women, is what she said. Because she also said women are those who go through a lot more trauma. So she said we want to probably look at that sort of independence, and that is something that will get through only when we have a housing program. So she's saying that if the government can help with that, it's very useful. And she's saying in Bangladesh as well, if we can do this, it will be very useful for women like me, is what she said.
Thank you again. Very rightly said. Very rightly said. The battle for the women folk is much much harder, and we all understand that. I would like to thank everybody for being with us, and I think we had a very fruitful discussion, much needed discussion. We should be having these discussions more so that we can share our experiences and move forward with it. In this webinar series, we have the last webinar on 31st of October, and that's about mental health at the community level. I hope everybody would join there too. Till then, have a great week, and thank you for being with us. Goodbye.
Thank you very much.
Thank you. Bye-bye.
Bye-bye. Bye.